Welcome back to Open Med School. Today I'll be discussing Indian Medicine Competency 8.3 Genetics of Hypertension. Hypertension affects approximately one third of adults and is extremely common. And what is the reason some people are affected and some are not affected by hypertension? The answer lies in genetic plus environment. So, how much is genetics? Before that, we look into what is the contribution by the environment, that is the diet, lifestyle, microbiome, and stress. This plus genetics lead on to, for in a susceptible person with the environmental factors, lead on to high blood pressure. So what is the contribution by genetics? Approximately 30 to 50% is heritability. So half of BP variation is due to genes. There are mainly two types of genetic influence. One is monogenic, second is polygenic. And sometimes hormonal changes due to somatic mutations. These are the basic things you should remember. What is my monogenic hypertension? They are rare single gene mutations producing a large effect and lead on to severe hypertension. Polygenic means multiple genes, they have got smaller effect but all together may lead on to high blood pressure. So key features of monogenic are they are rarely onset, monogenic, seen in young patients, often runs in family, and severe hypertension. The mechanism is abnormal salt handling, salt retention, fluid retention, and increased blood pressure. And sometimes lead to excess hormone production like aldosterone. Hyperaldosteronism can also lead to sodium retention. So polygenic is the most common, hundreds of genes. Each gene has small effect altogether in susceptible person leading to high blood pressure. This has been identified by the genome-wide association studies called GWAS. The affected systems are kidney, adrenal gland, blood vessels. So, and hypertension is a complex trait and not a single gene disease as per this polygenic theory. And the fundamental role is that of kidney. Most genetic forms affect sodium handling by kidneys. So that is one point to be remembered. Kidneys are the major reason for high blood pressure due to genetic causes also. Some hypertension is due to hormone related. And remember, they are not inherited, they are due to mutations in somatic mutations. Some of them are hereditary also. Example is adrenal tumors, pheochromocytoma, pituitary tumors, renin secreting tumors. Again remember, somatic mutations, they are not, need not be inherited. So think about epigenetics. Genes are not everything, but their expression matters. Epigenetic changes means they do not change the DNA sequence. Sequence of DNA is not changed, but the gene activity, gain or decrease in the action of genes can occur. These are the environmental factors mentioned earlier: diet, stress, environment. That is, a high salt intake changes gene expression, increase in BP. A person with a genetic risk, a high salt intake leads on to severe hypertension. Healthy lifestyle, there is no hypertension. So this is what is mentioned. BP is 30 to 50% genetic, monogenic theory, polygenic theory, and hormonal. Most genetic effects affect the kidneys sodium handling. And here comes the importance of the epithelial sodium channels. They are located in the distal nephron, mainly in the collecting duct. They allow sodium reabsorption. So this is the urinary side, and these are the epithelial sodium channels. They allow the sodium to get inside. And on the other side, by the sodium potassium ATP is pumped. Sodium is entering the blood. So when the increase in the sodium in the cells, the potassium will move out. So most of these cases are associated with hypokalemia, decrease in serum potassium. So epithelial sodium channels play a major role. So here you can see the epithelial sodium channel, the collecting duct mainly. Sodium is entering, and via the sodium potassium ATP is pumped, it enters the blood. Remember, the epithelial sodium channel is strategically distributed in various organs like brain, hypothalamus, heart, and the blood vessels. So it has got a strategic locations. The physiology of epithelial sodium channel I have already mentioned. Sodium enters via the epithelial sodium channel, and the sodium potassium ATP pumps the sodium into the blood. So this regulation of epithelial sodium channel, aldosterone increases the epithelial sodium channel activity. So the aldosterone will increase. ADH has also mild effect. The activity of epithelial sodium channel is increased. Angiotensin 2 has also indirect effect. Epithelial sodium channel activity increases sodium retention, volume expansion, and hypertension. Remember one condition, the Liddle syndrome. It is a gain of function mutation. The epithelial sodium channel stays active. So the sodium channel remains open for a long time. And the renin is without aldosterone. So you can remember it is a Liddle is low in renin, low in aldosteronism. So hyporeninemic, hypoaldosteronism, Liddle syndrome, severe hypertension, and hypokalemia. Apparent mineralocorticoid excess is another condition. The cortisol stimulates the epithelial sodium channel. The same way, the epithelial sodium channel is opened by cortisol. That is what is called apparent mineralocorticoid excess. Epithelial sodium channel opening is stimulated by cortisol. This leads on to hypertension. So, majority hypertension is polygenic. Small gene variations affect epithelial sodium channel. And salt sensitive hypertension. It is very common in the population. Many drugs are acting on the epithelial sodium channel. One is amiloride, second is triamdrine. They block the epithelial sodium channel, decrease sodium intake or sodium absorption or reabsorption, and the BP is decreased. So the clues to genetic causes are early onset hypertension, resistant hypertension, hypokalemia. That is a very important point to remember. Low renin, low aldosterone. So today we have discussed about monogenic theory, polygenic theory, hormone-related hypertension, and few words on the epithelial sodium channel, how it affects the sodium retention and hypertension in many of the salt-sensitive hypertension.